Good afternoon. My name is Brian Reif, and I would like to welcome you to today's Activity Strong webinar, Deprescribing through Life Enrichment and Interdisciplinary Care. For today's webinar, we are providing one free NAB, NCCAP, NCCDP, NCTRC, and NZSRTD CEU credits. To be eligible for the CEU credit, you need to remain on the webinar for the full hour. At the end of the webinar, we will be providing the post-webinar CEU survey evaluation link in the chat room box, and you will also receive it by email this afternoon. Please make sure that you check your junk and spam folder for this link. The survey must be completed by midnight Eastern Standard Time this Thursday. If you have any questions, please email webinars@linkedsenior.com. The CEU certificate will be issued by email before the end of day on Friday. Again, please make sure that you check your junk and spam folder for this email. Now I'd like to turn it over to Charles. Thank you.
Thanks so much, Brian. Hi, everyone. Welcome to our last Activity Strong webinar of the year. Super excited to have Delon Canterbury with us. Delon, thanks for being there. I know I'll introduce just in a few seconds, but I'm very excited to have you. I know we connected on this topic a few weeks ago, and that one for sure is one that is very dear and near to my heart, to our heart. Before we get started, just a kind of a little intros for the people that are new or new-ish to Activity Strong. This platform was started by Link Senior in partnership with Activity Connection, NAP, and NCAP. And it's all about elevating, empowering, educating, acknowledging activities and life enrichment professionals. So we're here because we're your biggest fans, and then we're fans of your fans in the sense that anyone that values life enrichment and activities should feel welcome, and hopefully you will all learn something today. A quick note, obviously we're using Zoom, but in the chat, feel free to select the drop down that says everyone so that everyone can see your valuable contribution. I see many people that are welcoming each other. Feel free to drop where you're from, saying hello to your other audience member, and we're going to get started. So just a few slides just to give background on an update. So one big update that we wanted to share is that we're very excited, and I wanted to pause and thank Emily on our team for all the work that she's been doing on the background in terms of merging all of the Link Senior resources with LifeLoop. And if you're asking why is that? Well, as I mentioned briefly, Brian mentioned, my name is Charles de Vilmorin. I co-founded a company called Link Senior about 16 years ago that was recently acquired, and when I say recently, over the summer by LifeLoop. And we're extremely excited to continue working on this merger, on this integration. And a little bit about myself, my world changed when somebody recommended that I get certified as an activity director through MEPAP 1, through NCAP, which I highly recommend. And I'm also known to have a second job in life, which is to give out these old people to call stickers. And I just feel that everyone is cool, including our elders, our older adults. So these are initiatives that we really firmly believe in. Again, one of them is old people are cool, and the second one, like we just mentioned, is Activity Strong. A few things about LifeLoop, besides the fact that it's one of the longest standing organization. Some of you might be aware of it. It's never too late. But we joined forces with LifeLoop and then joined forces with Link Senior. And I am so excited to continue, especially as we delve into 2025, just recognizing the amazing accomplishments we've had, including the McKnight Gold Winner Innovator of the Year, and just looking at what we're going to be doing in 2025. If you have questions about LifeLoop, think of it as the broadest life enrichment, resident engagement, resident experience platform out there. And our main goal, our only goal, is to help senior living communities flourish through enhancing resident experience, staff experience, and obviously connecting our family members. And it's interesting because obviously some of these items, Delon today is going to explain why and how to do some of that. So it kind of connects well with our presentation today. We're very focused on key pillars to help senior living flourish: efficiency, engagement, connection, and analysis through our platform. And which kind of takes us, yeah, to our topic today. So I love LinkedIn, and you meet amazing people, and Delon is one of the person that I was very lucky and fortunate to meet, as we had a common friend that recommended we speak. So Delon Canterbury is the CEO and founder of an organization called Geriatrics. And the topic we're going to talk about today is deprescribing, right? Deprescribing through life enrichment and interdisciplinary care. I will let Delon explain some of the details about the process and what it entails. But let's just say that in terms of introduction, it is an art. And it is an art that we have to learn through expertise like Delon's sharing today. And you cannot deprescribe unless you look at life enrichment, what we all do in activities, and this idea of collaboration among different departments, which is often one of the areas where we all need to improve a little bit. So with that, dear audience, I give you Delon. Very excited to be with you, Delon. I'll pop up at the end of your presentation with questions and answers. And yeah, excited to have you. Thank you for being here.
It's a pleasure to be here. Thank you for having me, Charles. Always good seeing you. And welcome, 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 everyone taking in their time during the busy holiday season to tune in today in the world of deprescribing. As mentioned, my name is Dr. Delon Canterbury, board certified geriatric pharmacist and founder of Geriatrics. So it truly is a pleasure to be here today. I am excited to share with you my journey as it relates to pharmacy, as it relates to geriatric medicine, and more importantly, how it can help you, our caregivers and clinicians, advocate for what's best and what's safe for our aging adults. So we'll dive into my why today, but I would love to know generally up front, how many of you in the room are a caregiver right now? And to double down as a bonus question, how many of you are managing more than, say, 7 or 10 medications for yourself or for your loved one? This will help give me a little context and hopefully give you guys some next steps when it comes to really auditing and assessing the true necessity for some of these medications today. All right. So let's dive on into our topic discussion. We will be talking about deprescribing. So first and foremost, I am not looking for a lawsuit. So everything today is going to be, of course, educational and intended for you to discuss with your clinical provider if you choose to use this information in your care. So geriatrics, what do we do? Who are we? I started this company in 2020. Specifically focusing on helping older adults minimize their pill burden, all right? So we focus on addressing duplicate medications, polypharmacy, overprescribing, and more importantly, improving the quality of life when it comes to choosing certain medications for our aging adults. And I find, unfortunately, we don't have access to specialists like pharmacists who focus on this area or this niche. So I felt there was a way I can work outside the lines of your traditional pharmacy role. And so we do not fill any medications. We are a pharmacist service without a pharmacy. And so that's where the word concierge comes in. Doesn't mean expensive. It simply means we work for you. We don't work for big pharma and we don't work for insurance companies. We focus on the minimizing of harm from your potential med list and challenging you and our system to ask, do I still need to be on this medication today? And so how do we do this? We partner with your prescriber, we partner with your care partners, and of course your caregivers, and we collaborate as an extension of your care team, focusing on what matters most to you and the family. How do we preserve your mobility? How do we preserve mindset? And of course, how do we look at those meds to make sure they're not conflicting with the aforementioned three? So let's get down to the true ugliness that we see in our healthcare system, okay? I have no problems with medications. Medications have been around for centuries. They've been healing us. They've been helping us live longer. And we have a lot to thank for the pharmaceutical industry in helping us extend our lifespan. They work when they work. The problem is we don't ask enough, is it still working? And so when it comes to chronic disease and treatment, about 80% of the things we'll use to manage your conditions are going to rely on some form of pill. So how come only 13% of primary care doctors actually consult with a pharmacist before writing a new prescription? You see, there's a little bit of a discrepancy there. And because of that, we do see harm in older adults, especially where about 750 people over 65 are hospitalized just because of a medication-related side effect. All right. So this amounts to nearly 275,000 people that die each year because their medications are not managed well or optimized. And so we know that we have a growing senior population here, about 10,000 people turning 65 a day, and that'll be about 50 million or more in the year 2030 up. So how come we don't have enough people, especially pharmacists, advocating for, well, making sure that your meds are actually the best things for you? About 30% of our older adults are taking at least 5 or more meds. And when you hit 65, about half of them are taking at least one med that's potentially inappropriate. So, hey, this is happening right here in our own backyard. So if we know these stats, why aren't we using pharmacists to work directly for you or even for your clinician's office when it comes to really get into the nitty-gritty of whether this is the right thing for you? And as we age, the medication side effect profile actually isn't the same as when we were younger or in our 30s and 40s. You become more sensitive to medications. Our bodies don't clear them the same. Our livers don't work the same. The way our gut works to absorb the medicines aren't the same. Yet we don't think of that holistic picture when it comes to healthy aging. And that's the piece of the puzzle that geriatrics is providing in our communities today. So let's start from where I began. I was your traditional Walgreens pharmacist. I actually have a practice here in Durham, North Carolina. I'm originally from Atlanta, so shout out to ATL. But I moved here in 2010 to pursue my doctorate of pharmacy from the UNC Eshelman School of Pharmacy. And so after completing my school there, I can only find a job as a community pharmacist. And so I ended up working all over North Carolina, eventually in a small town called Henderson, and was the pharmacy manager there for about 3 or 4 years. I loved working with the people. As you can see here, I got some texts making me some dirt cake for my birthday, but I enjoyed, more importantly, being in the community. I love doing career days. I love going to wellness centers and doing HIV and AIDS walks. So I was a pharmacist who really liked to be involved where I was working. And that's always been a part of me. But I learned very quickly that the business side of pharmacy, at least in this setting, didn't really align with the care I wanted to give to my clients. And a lot of my clients in this city were older adults. They did not have people advocating. In fact, the town doctor recently passed, and so a lot of patients were falling through the gaps of our health system, being forced to use the urgent care as their primary care. So in this setting, after seeing countless older adults come to my counter with long, unusual med lists, I quickly learned I did not know a thing about geriatric medicine. I'll be honest, I did not learn this in school. It wasn't a specialty focused on it. In fact, we talked about it for maybe 2 days and it was on to the next topic. And that's a disservice. That's a disservice to our aging folks, which we all will be. And yet, and still, I found there was a need. So what did I do? After being, frustrated, depressed, pretty angry with the healthcare system, I wanted to serve that community a little bit more intimately. And in that setting, I ended up pursuing a board certification in geriatric pharmacotherapy in 2017. So that essentially means I have a credentialing from the board pharmacy specialties to manage older adults. And guess how many pharmacists have that licensure? Yeah, only about 1% of pharmacists even carry that certification. So even within healthcare, let's be honest, we just don't have enough aging service providers that are masters in this specialty. We can't find enough geriatricians. They're one of the lowest paid doctors out there, yet they have the hearts of gold and do amazing work. We don't have enough caregivers. We know that the aging industry can be difficult to maneuver, and it can be quite confusing. So we're here to hopefully shed some light on how you can navigate that. So I mentioned, having that depression and anger in that setting. And truth be told, I wasn't able to get paid to do the stuff I enjoyed most. It was more, how much can you fill? How fast can you fill it? How many cool surveys can you get? How many flu shots can you give so you can get your bonus? And doing things with less, all right? Not all traditional pharmacy settings are like that, but unfortunately, when you're dealing with big bucks, companies, it ends up being about the metrics more than the person in front of you. It got to the point where I didn't even want to consult with my own clients, and I became super annoyed with just the system itself. And more importantly, I felt I was actually adding to the problem. I felt I was just filling things, yes, with my safety checks in mind, but I wasn't authentically doing what I know all we can do to advocate for less is more. So what did I do? Eventually in 2020, I decided to step away. I, again, was not in a good headspace. And I started just volunteering. Now, mind you, I didn't know that COVID would hit. So that became an interesting stepping stone in starting a business. But that was the year I did so. So in April 2020, at least for a few months, I worked for the Poison Control in North Carolina. I ended up being a part of the COVID task force. So the African American COVID task force, we focused on trying to get vaccinations and COVID screening. Remember when we didn't have vaccines? Yeah, that was a tough time. And so pharmacists did a lot of the heavy lifting in vaccinating our country. And we were on the front lines educating people about some of the misinformation with the vaccine, how it was made, and more importantly, advocating for our older adults to get vaccinated because they're the ones who are unfortunately dying the most. Additionally, I worked for a nonprofit called Senior Pharmacist, helping seniors and caregivers choose the right Medicare plan while saving them about $700 on average between each year of choosing. And also served as a telehealth director. So let's be honest, this moment of where do I go? Where do I become this person you may see today? It took a while to get to that journey. It took a while to find that sweet spot, but I started doing what I love most. I stepped down from a place that was toxic. I decided to choose what was happy for me and build a business out of it. And more importantly, I got to show up for my community. I got to show up for people that looked like me or meant the most. And I felt I was being able to be an advocate and a confidant. So in addition to that beginning, I'll have to share that a part of the bedrock of me getting into aging started before I was even a pharmacist. It started with my grandmother, Mildred, which we'll go into a little bit later on in our case. But my grandmother had dementia. In fact, she had moderate dementia while living in assisted living in New York. And we found that she was steadily declining over a couple of months. So much so that we had to move her from New York down to Atlanta. It just got too bad for the facility for them to manage. And my parents, my mom, Sandra, and my dad, Stanley, ended up becoming full-time caregivers and had to move them into their house and essentially childproof things so she wouldn't get into trouble around the home. It took us about 4 or 5 months of caregiving hell to realize that she was taking one medication that we trusted, one medication that we thought was the answer, but we found out it actually had an FDA black box warning saying it is inappropriate to use for someone who has dementia. Okay. So that was kind of the needle in the haystack for me that led to this, you know what? Aging needs more advocacy. It needs people who have this clinical expertise to speak up. And the only reason my grandmother lived to see 90 was because a pharmacist in Rite Aid helped my mom when she was discussing how much she has declined and was able to get the medication stopped and reverse what were thought to be signs of moderate dementia. So what do? We believe in the world and the power of deprescribing. But guess what? You don't have to be a pharmacist or a clinician to kickstart deprescribing conversations. We'll go into those details later on today. Part of the ways we implement this is by being your team member. We work for you. We don't work for anyone else except for families. And we provide concierge medicine by giving you a membership-based model to work with our families. We also provide genetic testing, so we get under the hood and look and see how does your body respond to meds, not just by using the trial and error approach we may see. And more importantly, we advocate for our caregivers. So let's dive into a case. I always love giving a case presentation to really drive home what all you can start thinking through as it may relate to you or your loved one. So we got an 80-year-old woman who is presenting with chronic constipation, increased confusion, memory loss, irritability, doesn't have any energy, and has had a lot of dry mouth lately. The patient's daughter is her caregiver, and she's been living at home with her daughter, but she has described her as being a walking zombie over the past few months. Let's take a look at the medication list. Now, I don't expect you to know what each and every one of these things may do, but if there's anything that jumps out at you, throw it into the chat. What are some things you may notice in this person's medicines? Have any of you guys seen these medications before? Have any of you guys maybe had any side effects or had any benefit from using any of the medications? How do you feel about her adherence? How do you feel about the combination of medications? You know, I'll give you a couple seconds to just throw any comments in the chat if you see anything that jumps out at you. There are too many of them. Yes, Charles. Over-medicated. Thanks, Carol. Too many, Lydia. Exactly. Yeah, 18 medications, guys, in a 70-year-old or 80-year-old woman. Generally, you know, that's a red flag. Like, oftentimes the medications are not absolutely vital to live, right? It's okay if some of them increase your quality of life. Awesome. But do you truly need all of these? And as you may notice, some of them are over the counter. Someone also mentioned, yeah, one of the meds doesn't even help with her symptoms, right? That's awesome. Some conflict with each other. Brilliant. So seeing all this, and yeah, lots of pain medications. Indeed, we do have a lot of pain medications. Yeah, I completely agree, Dottie. We can absolutely use dementia-friendly therapeutic approaches to manage and mitigate some of these meds, especially when it comes to behaviors, which was frankly what happened with my grandmother. She's missing a bunch of doses. Brilliant. Excellent. Thanks, guys. So yeah, let's drive home the kicker. Unfortunately, that wasn't all of her medications. She was taking even more. This is the rest of her med history list. Yeah, this is the rest. She was taking a slew of OTCs and supplements. She was having difficulty sleeping. So there were some interactions with some of the Benadryl prescriptions, with some of her antipsychotics. There were tons of duplicate therapies, tons of meds that are doing the same thing. Bonus, there was a medication that's intended for men for bladder, like for instance, she was on a medicine called tamsulosin, which is meant for men who have prostate issues. Why is a woman on that? It makes no damn sense. They didn't realize that the Tylenol PM also had Benadryl in it. So guys, I think it's safe to say you gotta have a pharmacist. Like you gotta have someone really look under the hood and see, is this appropriate? And frankly, this will help make life easy for the clinicians in using these type of services for all around holistic care. And yeah, some of these meds she may have stopped or used occasionally. Some of these meds, they're just trying to get her to feel better. And so, yes, Marjorie, asking key questions like how many of these things are actually working, that's the number one question people can ask. And it doesn't necessarily take a pharmacist. You as a caregiver will know your loved one's body. Sometimes it's, you know what, she knocks right out once I give her that med, or I notice she's dizzy afterwards. So great discussion. I'm glad you guys kind of keen in on how essentially a deprescribing advocate works. Yeah, it may help to know what the drugs may or may not do, but all of your instincts are right, guys. This isn't as clinical as we want to make it out to be. Oh, but no, and that, Marjorie, to your point, a lot of these meds were prescribed by different specialists, which is what we see often. There isn't communication between one provider and another provider and another provider. And so it ends up really, you think, oh, it's all in the same health record. They must be looking, guys, let me be honest, they aren't looking like that. They are focusing on the kidney if they're the kidney doctor. They're focusing on the heart if they're the cardiologist. And generally, there isn't a care person or clinical person unless you have a pharmacist embedded looking at all of the pictures. Honestly, it's just not being done. The most you may get may happen in an annual wellness visit. And if you aren't getting that in your annual wellness visit, that's one tip I'll leave you with today. If you got someone on Medicare, they're required by law to provide a comprehensive medication review as a part of your annual wellness visit. Make sure you schedule a separate meeting just for the medication review, not just to do a checklist that says, are you still on this? Yes or no. That's not a med review. All right. A med review thoroughly goes through each one and asks, is this necessary and vital now? And assesses, can we potentially stop this? And yes, supplements and OTCs can also be as dangerous in combination with some other meds. All right. So I mentioned, yeah, so not every provider is going to look and see all the meds, especially if they may use different health systems. And, sometimes that's just what it is. Not everyone's looking up the other system's health records to do a formal review. All right. And that's why it's important for you, guess what, the caregiver or the patient, to have an accurate and up-to-date list of everything you're taking. Because I can't tell you how often there are errors in the medical record, assuming you're taking these meds. All right. So we know that this is a huge need. And so this is why we partner with providers and we partner with families and do the care coordination around this. And one of the ways we do this is by, of course, CE training, just like this. But also, we provide deprescribing workshops for community members who want to just have a nice soft check on, is this necessary for us now? I guarantee you, I had no idea that my career would take me down this road to become a voice for the older adults when it comes to med safety. But I'm grateful it has. This is one of the best things in my life is in stepping down from my old job, it just helped me get my passion back for my career, but more importantly, for helping older adults in communities. But one thing you can do today is simply ask, am I on too many meds, or is my loved one on too many meds? And you could have 5, you could have 20. There's a good chance you could probably stop at least one, okay? So we help clients all over the country. We are concierge, again, private pay practice. We don't take any insurance, essentially using a flat fee model and a monthly or a 6-month or 12-month program. but we've got clients all over. You can check out our Google review page. If you have the time or ability, follow us on LinkedIn. We make tons of posts and content around this subject. And follow us on our YouTube page at Geriatrics. We provide videos going really in depth on how you can use Deprescribing without, again, being a pharmacist. So this journey has allowed us to go and speak. And honestly, I love that I can be on so many platforms. But everyone, frankly, needs a pharmacist. Everyone. And, sometimes you can go to your community, but I prefer you check out your mom and pop pharmacy if you have one in your neighborhood. They're the ones who tend to give a little more extra love and time and extra care when it comes to some of those care needs. All right. So what exactly is Deprescribing? This part of our presentation, we'll kind of dive more into the technical pieces of it and how you can promote it, okay? So when it comes to Deprescribing, right, it's kind of a newer term, but it's been around since probably, I'd say 2004, at least in the literature. But essentially, Deprescribing is the safe and monitored removal of medications that may no longer be necessary. All right. There are many words for this: medication optimization, medication tapering, medication withdrawal, basically medication reduction, whatever you want to say. But ultimately, Deprescribing is getting people off meds that aren't necessarily needed. Okay. And why is this important? I mentioned a little bit about this earlier, but our older adults, simply put, their bodies are not the same as when they were younger. And that means their side effect profile is actually increased when it comes to these same medications that were fine 20, 30 years ago. They may not be appropriate now. And, we've heard all types of concerns about the opioid epidemic and trying to get people off of opioids, et cetera. But Deprescribing isn't just for opioids or sleep meds. It literally can have a role in a number of health conditions and clinical settings. And frankly, when it comes to older adults, it can be appropriate for blood pressure meds, for diabetic meds, for even some pain medications. All right. And so it matters because when you've got an aging population that frankly has 1% of geriatricians, 1% of pharmacists that are focused on geriatrics, a lack of specialists within the hair care system embedded to literally say, you know what, let's stop, take a pause, and actually see if this is the best regimen for you. Let's be honest. What happens? You say your knee hurts or you got a new issue, you tell your provider, they put you on a new pill, and then you take the pill, you don't like the pill, but now you're on it. Now you see another doctor or you transition to another facility, they keep the same pill going, and it ends up being this circle of madness where truly no one is really looking to stop and get you off them unless you, the patient, says something about that. That's the model, frankly. It's a sick care model. I'm not a fan. But the truth of the matter is, unless you vehemently say, you know what, I just want to get grandma off of at least 1 or 2 meds. Can we have an ongoing conversation? And here's the kicker. Prescribers want their clients off of a lot of meds. They want less is more. They do. It's not a big secret. They prefer it. The issue I find is they often don't know where to start. They don't know how to have that conversation. And frankly, unless you, the patient, brings that up, they're thinking everything is business as usual and everything is just hunky-dory. And yeah, we expect providers to review all the meds, and I'm not saying they all don't, but is that going to happen at every visit? Unlikely. Is there a deep dive that a pharmacist can do who literally has a degree in drug pharmacotherapy versus a couple of weeks of schooling around their favorite meds they like and they just use the same meds over and over? We're not here to tow against providers, but we all know our skill sets. I cannot diagnose a fungal infection from a bacterial. So you don't want me diagnosing a tumor or whatever. And that's what doctors are amazing at. That's not my job. My job is med management and looking to see if this is appropriate based on your whole clinical picture. We have different lanes, but the truth of the matter is prescribers, physicians love when pharmacists help them out when it comes to these med regimens. This happens all the time in the health systems. They appreciate what we do. So when I work with my clients, they're finding relief that there is someone actually doing the part of their job that they frankly don't want to do, nor really have the time to do. There's so many competing priorities. So that's why this is a service that kind of is a win-win-win for all. So really the goal for me, just like what happened to my grandmother, and also what I'll share with that client we had who was on about 36 medications, the goal of deprescribing is to reduce harm. It's to improve quality of life. It's to improve your wellness, and it's to help you age safely at home as long as possible. That's the mission. Simple and plain. In that very same case that we had presented, we were able to help that family minimize that medication list from 36 medications down to 8 medications, all right? And eventually they even decreased it further down to 3 medications because we were able to get to the bottom of what all of those issues that were presenting as dementia were. When in actuality, it was about 5 or 6 meds that was leading to this condition that looked like she had dementia. And the kicker of this part is that the family was torn on whether they need to involuntarily commit her into a memory care unit. Ladies and gentlemen, do you guys know how much it costs to afford a memory care unit on average a month in this country? It's, we're looking anywhere 8K, 15K a month. All right. We were able to help this family out for less than $1,000. I mean, $500 to do the review, $500 to go to court and go to talk to the doctors and make it all happen. So just over the lifetime of us helping her get off that med list, we've saved them well over $500,000 just in the cost it would have said to frankly get all this stuff done. All right. So yeah, when someone asks, when do you ask? It's always a good time to ask. In fact, I make sure I coach my caregivers and clients to always ask at every visit, hey, I would like to reduce how many meds I'm taking. What's 1 or 2 meds that we can stop or reduce the dose on and see how I do in the next 2 months or in 1 month, depending on the clinical condition. And if you do well, you can continue to taper it off. But your job is to honestly ask, when can I get off, or when can my loved one, change a lifestyle habit? Can they work out more? Can they change their diet? What are some things we can do to reduce the need for this med? All right. I've seen water be the way. You cannot express how many people are dehydrated, and drinking more water can reduce the need for an NSAID or ibuprofen or something if you have a headache. A lot of times we're dehydrated. So that's one way. And that's the strategy we like to employ first, is what's non-invasive, what's easy, what's cost effective, and what actually is proven to help improve care. That is the way healthcare needs to be. It's using this integrative approach between clinical and of course lifestyle that gets that awesome outcome that we have. So I already mentioned that overprescribing, or even just really the overuse of medications, increases the risk of having a bad drug reaction. It's been statistically shown, like if the more meds you're on, the more increased risk of confusion, of falls, constipation. You can pretty much name any side effect, and there is an association with that. There's even an association in mortality. So people who take more than 10 within an assisted living facility setting, at least from a study in Ireland, have shown almost a 3% increase in mortality. So basically, guys, the longer your med list, the more likely something harmful is going on. And that does include over-the-counter meds and supplements as well. All right. It's not just prescriptions alone. So your question really should be, what are some things I could change with diet, with exercise? Frankly, preventative medicine is the way to go. We don't talk enough about it, but that is the cornerstone to healthy aging. Keeping yourself moving, keeping yourself active, and of course, making sure the medications are not conflicting with any of those other goals you have in your life. So how do you kickstart this conversation? Like Judy asked, when's a good time to bring this up? It's always a good time to bring this up. Frankly, the more you repeat it, the more there'll be prescriber buy-in. And yeah, sure, maybe there are one or two meds that they do not want to stop at the moment. That's fine. You bring it up again. This is not a game where we just play soft and hope, oh, well, we tried. No, if you still see someone who is likely or is possibly getting worse while on a number, a huge number of meds, maybe over 10 or 15, etc., you want to minimize that because the stats don't lie. More people are at harm if they are not being reviewed consistently, and we have higher risk of side effects that we can probably avoid. You also want to understand that there are sometimes risks in stopping a medication. Sometimes there are barriers clinically, sometimes there are barriers from the patient standpoint. So depending on what type of medication it is, you want to make sure you're not just stopping certain things cold turkey. That can actually cause a symptom to significantly come back. It can also cause a reflex condition where whatever you were treating before actually gets worse. So that's why we got to make sure you're doing this with a supervised clinician if you're going to go down that route. And so what we do is start that conversation. We kickstart that conversation for you and your family, focusing again on what's best for you. Now, we're not just coming in and saying, you know what, let's stop everything. That's inappropriate and not safe. But we do focus on what matters most to you. And then if that medicine may conflict with what matters most to you, it may be, say, increasing a risk of harm or a side effect, then easily that is where we will focus our deprescribing efforts. And that's why this is a shared decision-making process. It's always good to bring this up and ask, what are some non-pharm strategies or alternative approaches that are proven that we can attempt before adding on another medication. So I mentioned that this essentially what we saw in that case was very similar to what happened to my grandmother, which was what got me essentially into geriatric medicine. Her name was Mildred. But I'm honestly sick and tired of just letting people fall through the cracks. Like, what if my mom didn't go to that pharmacy and complain about her side effects? What if that family in our case earlier didn't know to reach out to me to do a medication review? Why are we waiting and hoping that we get this from our standard of care when it's not being delivered as the standard of care? I've already showed you that we don't have enough people to do this. And even so, we really don't have people that know that deprescribing is actually an option. It's not, we're in a medication culture. Let's be real. We've been trained to believe that you have to be on that baby aspirin for the rest of your life, or you have to be on this forever and ever without any question, because that's the culture and society that we're in. Frankly, we like the quick and easy way. I like my microwave. I don't always want to put the stove on, but that's how we are. But I have to challenge us to that medication mindset. We have to shift that medication mindset and show that it isn't always going to be a pill that's going to be the answer. In fact, most of the times, it's not the true answer. The true answer is what you're putting into your body with your food and diet, and how are we shifting our behaviors to promote healthy aging. All right. And that's socializing with friends, going on a walk, moving your body, music therapy, spending time with loved ones, like being a holistic person, having spiritual growth and healing It's all of those things make us human. Medications have a role. Don't get me wrong. They absolutely have a role, but they're not always the answer long term. So one thing I want to make sure, and I'm curious if anyone has experienced this, and if so, put it in the chat. But this is a very common phenomena we see in practice. It's called a prescribing cascade, all right? Essentially, you come to my pharmacy or my clinic and we're treating your blood pressure. And now that blood pressure med from drug A is causing a new side effect, such as foot swelling. Well, instead of a clinician seeing that foot swelling as a side effect, they inappropriately see it as a new health condition or something to basically treat. And so now you end up on drug B, which is now a diuretic, which helps to reduce the fluid, which was actually caused by drug A. Now that diuretic is causing you to use the restroom more and more and more, leading to overactive bladder. And so guess what? Now we're on drug C, which is meant to reduce the overactive bladder. And now that overactive drug is now causing dry mouth. Drug C is now introduced, and so on and so on and so on. All right. This is what's known as the prescribing cascade. There are over 300 plus examples of this in the literature. About 200 are commonly studied as the most, I guess, high risk. But frankly, I don't think this is really discussed or let alone taught in a lot of modern medicine. We see it especially in geriatric medicine, but not necessarily in other worlds. So this is the prime example of saying you have an issue, going to another provider, and now another med is being added to your list without always doing a full workup of whether there was something causing that to begin with. This is why geriatrics is in business. As sad as it is to say, we have to use pharmacists to identify these problems. I cannot stress how much this has contributed to hospital visits, unnecessary falls, confusion, and frankly, the very same reason why our client in our case earlier was on 36 medications. Apart from some inappropriate over-the-counter use, in addition to that, there were just meds that simply did not belong. 2 or 3 of those meds were the ones that were actually causing the urinary blockage. And then that's why they put her on a medicine, tamsulosin, which is intended for men who have prostate issues. You see? So, there's always a bit of a mystery when it comes to our cases. And as we do our deep dives and kind of work our way backwards, to me, it's like a Scooby-Doo mystery. It's like, all right, what's the one thing that started? Okay, they fell. All right, they were in pain. Okay, they had ibuprofen. Okay, the ibuprofen caused heartburn. Okay, now they're on a heartburn medicine. Now the heartburn medicine has an association with falls, with osteoporosis. Now they fell 10 years later. Now they have a broken hip. You see how this can easily cascade? It happens all the time. It happens all the time. And again, we have a system where we don't know what the left hand's doing with the other. We don't always have cross communication among all providers and pharmacists. We have general barriers as clinicians, where sometimes clinicians don't want to touch what another provider may have written. And so they feel it's etiquette to let them deal with it. And so there becomes this game of pass the buck or whack-a-mole or whatever. And no one's really taking accountability for that med list unless you've got your own pharmacist or deprescribing advocate. All right. And that's what we provide for all of our families. So again, we want to keep people at home. We want to improve quality of life. And we also want to make sure that you know that there are tools out there to assess this. All right. Ask what matters most. Make sure you have that annual wellness visit where you are separately discussing all the medications and all of the risks and benefits of keeping a medicine, along with stopping a medicine. There are tools out there that can help you. One of my favorite ones to use is the beers list. And yes, I also like beer, so you can buy me around after this. But the beers list is this geriatric list that essentially is a potentially inappropriate medication list that we use to look up and see, hey, you probably should not be on this medication based on its harmful side effects. That's what the beers list is for. It's freely accessible. You could do a control search and look and see if any of the meds that your loved ones are on are in that document. All right. But we have tons of tools that are out there. So I hope that today was helpful for you all. I do want to give each of you a call to action. One, take the time to jot my number down, shoot me a text message and our team, and check out our website. And of course, lastly, if you're on social media, follow us at Geriatrics. We are on all social media platforms. But if you have someone who fits, taking more than 10, 15, or even 20 medications, say me in the chat, and I would love to reach out to you, or at least more specifically, send us a text on the number on the screen. We'll be happy to do a review and at least walk you through what that future of less meds may look like for you. Again, it's my esteemed pleasure to be here today. I thank you all for the lovely participation, and I want to open the floor for any questions or concerns.
Thank you so much, Zidon. It's funny because like the Deprescribing has a long, it's been a long, it's been a topic of mine for a number of years for many reasons. One is that I really love memory care, I really love dementia care and so on. And as you obviously know, there's just too much polypharmacy and overuse of medication in these settings. One of the things that I found really inspiring, Delon, is when you explain that the bulk of your work is about reducing harm, right? Reducing harm. And spending so much time in memory care, really thinking about some of these medication as quote unquote chemical restraints. There's an element about saying also that you reduce harm, but you also help with freedom, right? You help people live more freely. So I don't know if you've ever thought about it that way. I don't know if that kind of jives a little bit with some of your values, but just would love to hear your thoughts on that as well.
Yeah, that's frankly the number one response we get from our patient reviews and testimonials is that empowerment and peace of mind that comes from knowing, you know what, we did everything we could to minimize harm. And the freedom of that is also liberating to know that, hey, you know what, I don't need to be on these 2 or 3 more meds for the rest of my life. This actually is causing me way more harm than good. And we do see tons of medical restraints or chemical restraints, in some of these, and especially in the dementia world, where we just use meds to, frankly, just sedate people and make them docile. Yeah. That's highly regulated, one, but two, that's generally frowned upon. And I get sometimes you don't have options, or we're just trying things, and there is some grace to be given in some of those cases, but oftentimes they are inappropriate and may not be necessary. So I don't want anyone to fall victim to that, like my grandmother did, or like our client did. I mean, frankly, my grandmother lived to see 90, so she got that freedom, and that happened about 10 years prior. So I'm grateful to that pharmacist that now has inspired me to pass that movement forward.
I mean, there's no question that your work is the future. Like there's no way we can improve the quality of the experience of our residents. I mean, when you think about the fact that nationally in skill, like in nursing homes, right, skilled nursing facility, we have a use of 14% of antipsychotics. That is just crazy. And I don't know if you saw in the chat, but I put something about the cost of all of that, right? Like there's a huge cost also. Like when you showed us the 2 slides of medication, I mean, like an activity director in senior living can do way better job for 10% of that cost when you think about it.
Oh yeah. It all starts with a conversation. Just starts with a conversation and someone who just owns that and looks to have that done consistently, and it'll change people's lives.
Yeah. So just given our audience, Delon, again, primarily senior living professional, primarily activities and life enrichment and their fans, what would be your word of advice about having these conversations, right? So for example, if I see one or two or more residents that, I think may be in this situation, what do I do next?
Frankly, get into it, and if you don't feel comfortable, have a conversation with a pharmacist or maybe a medical director, but ask, when was the last time you've had someone do a thorough look at all your meds?
Yeah.
And ask that intently. And if they haven't had it, invite us to the conversation. Let's do it together. We conduct deprescribing workshops for these very same facilities. So if you want us to come, we get 10 people who have the issue, we can have a round robin style and literally try to knock it all out in one setting. That's where aging has to go. And I'm happy to facilitate that discussion with you.
Yeah. So I don't know if you probably saw, but I was recommending, like, I love your LinkedIn and social media content. Let me just place again your LinkedIn profile. Oh, there's been so many comments here. It's great. Let me add. So everyone in the audience, just at least as a first step, my invitation to you all, especially as we start a new year, especially with new habits and so on, consider following Delon on LinkedIn. There's just a lot of content, whether you just started a conversation or you are a pro in partnering with your clinical team, with your pharmacists and so on. There's a lot of great content and a lot of great things to learn. Delon, any last minute thought or advice for our audience today?
I'll just answering some of the questions in the comments.
So
generally, we do try to remove one med at a time. It kind of depends on the case. If it's like easy stuff, so to speak, you could probably knock out a couple. But if it's one that we know might be causing a lot of harm, we try to do one at a time just to ensure that there's resolution. I'll also add, we do deprescribing training workshops. So we also train clinicians for a 15-hour live CE program with our deprescribing accelerator. So we train nurses, pharmacists, doctors, prescribers on how to implement deprescribing. And one of those topics is deprescribing for dementia. I told you that's one of my sweet spots. So I've done a number of trainings for caregivers around which meds may or may not be appropriate within a dementia population. So happy to drive that conversation forward with you.
Great. Well, again, thank you so much for your time today. If you don't mind unsharing my screen, your screen side, I just want to show one last slide to our audience. But like I said, Delon, like, your work is, I really believe it is the future, especially with your attitude of partnering, obviously with the elder, but also partnering with other team members that include, the activity professional, any actually professional on the floor, and obviously our family members. So thank you so much for this amazing, very educational content.
By show of hands, before you continue, is there anyone who wants to just start working today with our services? Please put it in the chat. I'll reach out to you. You just say me and we can go from there.
Thanks for that, Delon. And everyone, as we migrate all the resources of Activity Strong, here's just a quick update that I mentioned at the beginning. Actually, you just had a yes in the chat, Delon.
Awesome.
Just as a heads up. If you want to go to lifeloop.com, you'll see all the updates there. You can also flash your phone for the QR code to be redirected there. And last but not least, Delon, thank you, and wishing you a very, very happy holiday season. And I look forward to seeing you live in the real world one of these days.
Oh, yeah, most definitely. Thank you, guys. Have a great holiday. Appreciate you.
Thanks a lot, Delon. Take care. Bye-bye.
Bye.